I'm Einar Ottestad. I'm a full-time pain physician at Stanford, where I did my anesthesia training as well as pain fellowship. I distinctly recall as a resident being extremely excited about ultrasound. It was a fantastic modality, especially for placing central lines and difficult IVs. I was fortunate in the mid-2000s during my last year of residency. That was actually the first month that Stanford purchased a new ultrasound machine specifically for doing regional anesthesia. And in fact, I split my month doing nerve stimulation for 2 weeks and then ultrasound guided blocks for the following 2 weeks. It was especially an interesting experience because, of course, my attendings, my faculty, also had no experience with ultrasound. So definitely for that first year, it was an exciting time to be putting needles in people and wondering what the structures were that you were seeing. So during my residency training, I thus had a little bit of experience doing regional blocks. Then when I went on to do my pain fellowship, it was simply anatomic based and fluoro based, so I had to put away the ultrasound probe for those 12 months. It seemed fairly natural to me, however, when I started working as an attending, to consider applying the few skills I had learned as an anesthesia resident to the chronic pain world. Of course, back at that time, we didn't have any books. We had very few papers of any kind on ultrasound outside the previously mentioned basic regional anesthesia blocks and central line placement. The learning curve was actually very steep since I didn't have a lot of resources. So essentially, I would start off with looking at my schedule for the next day and what procedures I was doing. I would pick several that could be amenable to ultrasound and really sit down with the anatomy book. I specifically enjoyed Rohan's anatomy book, and I also had a ultrasound text from radiologist Martinoli and Bianchi. This would, of course, not be targeted at anesthesiologists without any interventions, but it did show me generalized ultrasound anatomy so I could start getting a sense of what the surrounding structures were to my target. So as I picked up one block after the other, I would simply try to understand that regional anatomy as good as I could, and then really still use my old techniques for the block, but I would add the ultrasound to it. By that I mean if I were blocking a nerve, I would combine ultrasound with electrical stimulation to confirm. And I would probably have to do each nerve block 4 or 5 times before I started feeling comfortable with what I was looking at. And then I could skip the nerve stimulation step. On the other hand, for joint blocks, MSK blocks, I would do a combined technique with ultrasound and fluoro. So I would simply place the needle using the ultrasound with the best technique I could come up with on my own, and then inject some contrast and take a confirmatory X-ray. And the same philosophy applied there. After 4 or 5 successful injections, I would then feel comfortable enough to skip that confirmatory step. Learning ultrasound these days is obviously a lot easier because we have probably 10 different societies giving ultrasound workshops all over the country and all over the world. And it's a lot easier to learn face-to-face with experts and pick these skills up significantly faster. In terms of learning speed, I would say even though I knew the basics of ultrasound as I started, I probably couldn't say I was proficient for a year or two in not just specific blocks, but just starting to use the ultrasound to its maximum potential. So what do I mean by that? It means understanding ultrasound and the anatomy to a point where it became a useful tool outside of just guiding a needle. So with nerve stimulator techniques, as I've been using previously, if I were targeting, say, a superficial perineal nerve because someone had complex regional pain syndrome, I could certainly get stimulation, inject some lidocaine around it, and watch the pain go away. With ultrasound, I don't stop at that step. I'll actually scan the entire length of the nerve and look for abnormalities. And I see nerve abnormalities in my chronic pain patients quite frequently. Over the course of time, that's improved my diagnostic ability, but also I can target my treatment to those specific areas of damage, and also that helps my colleagues, specifically nerve surgeons, know what the problem is and know where to cut. That has grown to the point that these days, before doing surgery, the surgeon will send the patient to me for pre-op nerve marking, and I'll simply put an X on the correct spot for the surgery. So she's able to do procedures now with much smaller incisions and find the nerves a lot faster and easier. Other issues would be, for example, if someone has shoulder pain, I don't simply look at the joint capsule and put the needle in. I'll actually be able to examine all the tendons and maybe know why they have shoulder pain. In terms of diagnostic ability, I wouldn't say that I would stop at that point. I'm still at the point where I would order an MRI for confirmation. But it's certainly helpful to put the probe on the shoulder and see a huge effusion, and then I can know what the problem is on the same day I see the patient. The other large advantage with that is the fact that I can do this at bedside in the office with a portable machine. I don't have to send the patient to the X-ray suite in order to have an answer to what the problem is. All that stated, ultrasound is fantastic for the soft tissues, for tendons, for nerves, for the diagnostic aspect as well as interventional therapeutic aspect. However, it's not perfect. It can't see everything, and I still firmly believe that when I'm working near the spine, fluoro remains my gold standard. Where do I think ultrasound research is right now, and where do I think it's headed? At this point, we mostly have papers validating ultrasound techniques, essentially similar to the way I learned ultrasound. They mostly consist of placing needles using the new ultrasound technique and taking a CT or an X-ray to confirm that, yes, these are the same targets that have been validated in previous studies. We don't necessarily have a lot of papers actually double-blind, placebo-controlled on patient and patient outcomes when these techniques have been used. And I think those are the next steps we have to take. I recently reviewed the entire literature to prepare for a talk on ultrasound-guided ablation, and I didn't find a single full, large, double-blind, placebo-controlled trial for radiofrequency ablation or cryoablation. We definitely have trials like that for fluoro-guided procedures, but I do think we need to prove that the more long-term outcomes with ultrasound will remain similar to fluoroscopy. The other half of the papers really are more anecdotal case reports. We came up with this neat block that helped these 1, 2, or 3 patients. We really need more comprehensive, I would say, more comprehensive papers with more patients. And I think that will also help validate the technique, make it more common, and have more people willing and wanting to learn to use ultrasound. Overall, I would say that now probably 80% of my practice is ultrasound based, and because I've been doing it for a long time, almost 10 years now, I have a large referral base where patients get sent to me specifically for some sort of ultrasound diagnostic or therapeutic treatment for particular patients. One example of that would be buttock pain, gluteal pain, and hip pain. The pelvis can be a bit mysterious with a lot of anatomy, and all pain in the buttock isn't usually piriformis syndrome. There's a lot of different anatomy that can be involved. So I frequently get patients sent to me to scan that area and try to figure out what is wrong with the patient after MRIs don't show necessarily a problem, and after spine procedures haven't been helpful. So usually I'll see that they've had epidural steroid injections, sacroiliac injections and facet blocks without any change in pain, but when you ask them to point, they point to the classic location where those structures would refer. So what I would do at that point is simply add the ultrasound to my physical exam, and as I scan over the pelvis, I can try to narrow down exactly where that pain generator is, and instead of simply guessing it's piriformis, I can just look on the screen and actually tell exactly what that structure is. I'll follow this up with a diagnostic injection with a little local, whether that could be a nerve, pudendal, lateral femoral cutaneous, ilioinguinal, or a specific muscle. And like I said, not just piriformis, but one of the gemelli, the obturator, even quadratus femoris, obturator internus. I've injected with complete resolution of pain. To be more specific, I also recall a case where an 80-year-old, very pleasant gentleman came in once again with buttock pain. And he came from a neurosurgeon who wanted to fuse 3 more levels of his spine because of significant and severe arthritis. However, he wasn't super excited about having surgery, so he wanted to see if there were any other options. On my ultrasound exam, I found an enormous subgluteus maximus bursa almost immediately. It corresponded with this location of pain, and when I injected a little bit of ropivacaine into it, his pain actually went away. So I managed to save him from having this huge lumbar surgery that probably wouldn't have made any difference to his pain after all, since the local injection into his buttock actually ablated all of his pain. At this point, he comes back roughly every 6 months for a repeat injection, and he's back to enjoying his life and going out on his boat and being as functional as he's able to be at age 80. So those are just some specific instances where without the ultrasound I probably would have been equally puzzled to the other 4 or 5 physicians that patient had seen. But with the benefit of ultrasound, not just for the injections, for the interventions, but actually to help with diagnosis, it's made a huge change in my practice and also helped me with creating a specific referral network to get these patients to see them and to be able to help them.